Hello, dear colleagues, dear friends. Today, I would like to guide you through a new case in the ASAS online case library. As you can see here, this is a 24 years old male patient presented to a rheumatologist because of presence of chronic back pain and suspicion of axial spondyloarthritis. This initial suspicion of axial spondyloarthritis is based on the presence of inflammatory back pain, with back pain that started approximately 1 to 2 years ago, rather rapidly, but with clear improvement with exercise, no improvement with rest, pain at night, morning stiffness of up to 1 hour in duration, irradiation of back pain to the gluteal region, and some response to NSAIDs, although there were some tolerability problems with NSAIDs. There were no other spondyloarthritis manifestations, no family history, and no other known medical conditions. On clinical examination, we saw a slightly overweight patient without any other pathological findings. HLA-B27 was positive and CRP was elevated with 60 milligram per liter. No other abnormalities were recorded. So in this case, we have a patient with clinical suspicion of axial spondyloarthritis who is B27 positive, who has an elevated CRP. So overall axial SPA is likely, but we would like to confirm, of course, the presence of inflammatory disease objectively. On X-ray of sacroiliac joints, we see, first of all, that there is no high-grade sacroiliitis. You see rather normal left sacroiliac joint and some subcondylar sclerosis in the right sacroiliac joint. It is always too difficult to judge on the presence or absence of joint space abnormality in the mid part of the joint because of anatomical complexity. At the same time, we have an lumbosacral transitional abnormality. You see that there is a connection between transversus process of fifth lumbar vertebral body and this sacrum. So normally such a asymmetric congenital abnormality results into a substantial mechanical stress, especially on the contralateral side. So it is not surprising that there is some subcondylar sclerosis there. And of course, that mechanical problem is associated or might be associated with back pain, with unspecific back pain with degenerative changes in the spine. So we need to be very careful in interpreting all other imaging findings. On the X-ray of the lumbar spine, there were no major abnormalities. The same was also true for the X-ray of the cervical spine. So as a next step, we performed an MRI of sacroiliac joints, and probably you know already that as of today, at least 3 MRI sequences are recommended for the investigation of sacroiliac joints with MRI in patients with suspicion of axial spondyloarthritis. First, there's a water-sensitive sequence like STIR or TERM or T2-weighted sequence with fat suppression. This is a T1-weighted sequence, and this is an erosion-sensitive sequence, sort of 3D gradient echo sequence in this case. This is a so-called WIPE sequence. So let's start with water-sensitive sequence T2 with fat suppression or STIR. You see, indeed, this is STIR. Water signal is bright, fat signal is dark. So inflammation would be depicted here as a bright signal. And indeed, there is a lot of inflammation here, or at least bone marrow edema, which is localized in many quadrants in both sacroiliac joints. And this bone marrow edema is large enough to be seen on many slices. So already based on this image, we can say that axial spondyloarthritis is very likely. However, you probably remember that interpretation of bone marrow edema is always conditional on presence or absence of structural changes. Axial spondyloarthritis normally results into a rather rapid development of structural changes, especially erosions and fatty metaplasia. So bone marrow edema, which is present on a background of structural changes such as erosions, would have rather high specificity, while bone marrow edema on a background of no structural changes at all would have rather low specificity. So let's have a look at T1 first. So T1, water is dark, fat is bright. And what you see here, there are structural changes. You see some defects of the cortical bone corresponding to erosions. You see fatty metaplasia of the bone marrow, fat lesions, post-inflammatory fat lesions. And erosions are here very well depicted by this sequence in the right sacroiliac joint and the left sacroiliac joints. It's rather hard to say whether erosions are present or not because of this dark signal that could be also subchondral sclerosis. And this is a situation where erosion-sensitive sequence is very helpful because it helps you to differentiate between sclerosis, which is very unspecific, and erosions, which are very specific for spondyloarthritis. And indeed, in the area where we saw only a dark signal on T1, we see in a wide sequence erosions, defects of the cortical bone, and erosions are also present in the right sacroiliac joint. So in summary here, we have evidence of bilateral sacroiliitis, very well compatible with axial SPA, and this judgment is based on the presence of bone marrow edema associated with structural changes, fat lesions, erosions, and some subchondral sclerosis. In this case, we have also a confirmation of this lumbosacral transitional anomaly, but we do not see here any evidence of persisting mechanical stress in this area. So there is no neoarthrosis, no new joint space here. So this is rather a coincidence finding. Let's have a look at spinal MRI, whether or not we can find here something compatible with SPA. So let's concentrate first on lumbar spine. And this is again stir sequence. Water is bright, fat is dark. And it is quite important that we always evaluate condition of intervertebral discs, because if the disc is healthy, water rich, bone marrow edema in the vertebral body is likely to be caused by spondyloarthritis. If the disc is degenerated, however, like in this case, you see a dark signal, the disc is dehydrated, then findings around this disc would be rather unspecific. In this case, we see some spondylitis anterior, so bone marrow edema in the anterior portion of vertebral bodies on several levels. And what you see here, that the discs are rather healthy in this case. So this bone marrow edema is likely to be caused by axial SPA. Do we have also some post-inflammatory changes in this region? To answer this question, we need to have a look at T1, and indeed there is some fat signal there, and this is likely to be a fat metaplasia after inflammation in this area. This case is also interesting because we have another finding in the thoracic spine, and you see here bright, sharply bordered lesion, which is quite inhomogeneous, and this inhomogeneity doesn't correspond to a lesion that is expected as a part of axial SPA. So this rather round, sharply bordered lesion is very well compatible with hemangioma, normally a coincident, fully clinically irrelevant finding. To ensure that this is indeed a hemangioma, we need to have a look also at T1. So hemangiomas are normally bright in stir sequence and also bright in T1 weighted sequence, because here we're dealing with a combination of many blood vessels. So they give you bright signal on stir, but at the same time we have fat tissue, and indeed this lesion is also bright in T1 weighted sequence. So we can say with a high level of confidence that this is indeed a hemangioma and not an active inflammatory lesion. So in summary, in this case, we saw some mechanical issues which might be associated with mechanical problems and with back pain in young people, like lumbosacral transitional anomaly, like degenerative changes in the lumbar spine. But at the same time, we also observed typical spondyloarthritis characteristic lesions on stir and T1, weighted MRI images from sacroiliac joints, very well compatible with spondyloarthritis. So the overall conclusion would be that this patient has indeed axial SPA on the background of some mechanical problems, which probably doesn't play a major role in this case. Thank you very much for your attention, and we will see next case in a couple of months.